Hello and welcome to Radcliffe Cardiology's webinar in association with Interventional Cardiology Review, supported by GE Healthcare. I'm Dr. Christopher Cook, Clinical Editor for the Radcliffe webinar series, and I'm delighted to be joined live by Dr. Marco Spaziano from the McGill University Health Center, Canada. Dr. Spaziano is going to be talking to us today about left atrial appendage closure, focusing on procedure planning and device positioning with advanced imaging techniques. During this webinar, we will revise our understanding of the morbidity associated with atrial fibrillation, the unmet need for thromboembolic protection for a significant proportion of these patients, and consider the indications for left atrial appendage closure. We will be guided through the key defining features of the various closure devices available, and we will discuss the challenges percutaneous left atrial appendage closure poses to the interventional cardiologist. Most importantly, we will develop our knowledge of how advanced fusion imaging techniques can help us plan, guide, and assess left atrial device deployment to real case examples. Before we begin, just a quick note to our audience. You'll have the opportunity to ask Dr. Spaziano questions via the text box on your screen throughout the course of the webinar, and Dr. Spaziano will answer as many as possible at the end. Okay, so I'm going to stop talking now and hand over to Dr. Spaziano to begin his presentation.
Okay, hi everyone, good afternoon. I'd like to thank Dr. Cook for the kind introduction. I'd like to thank everyone for tuning in this afternoon. We'll be discussing LAA closure and more specifically procedure planning and device positioning with advanced imaging. So here are my disclosures. So the plan for this evening is to discuss first quickly what's known about AF and the left atrial appendage. Then we'll also quickly discuss left atrial appendage closure devices and the challenges associated with the procedure. Next, we'll discuss at length MSCT fusion imaging, and we'll finish with a case example and discuss quickly our experience with this technology. So what's known about atrial fibrillation and the left atrial appendage? As you know, atrial fibrillation is the most common cardiac arrhythmia. It affects over 7 million people in the United States alone, and between 10 and 15% of patients actually have contraindications to oral anticoagulants. And what's interesting to see is that these patients with contraindications are actually those that stand to benefit the most from anticoagulants because they have the higher CHAD score and CHADS-VAS scores, as you can see in this study that was published in 2014. Now what's known about the left atrial appendage, so as most of you know, 91% of strokes in atrial fibrillation are caused by blood clots that form into the LAA, and this is related to stasis, the anatomy of the pectinate muscles, inflammation that could be that can occur locally, and fibrosis. So this site-specific etiology of stroke makes LAA closure an attractive treatment option for patients with OAC contraindications. Now we're going to discuss briefly the closure devices that are available and the different challenges associated with the procedure itself. So these are the two devices that are currently the most widely used. So there's the Watchman device and the Amplatzer cardiac plug, which has been replaced more recently by the Amulet device. These are both CE marked, and the Watchman device has also been FDA approved in March 2015. There's been over 30,000 implantations worldwide in more than 70 countries. And this somewhat outdated slide shows that the global volume is expanding, and mostly in Europe. And so what I can tell you for France is that there's been 800 procedures performed in the country in 2015, and that number has doubled to 1,600 in 2016. So there is quite important expansion of the number of procedures performed. Now looking at the challenges of this specific procedure, the LAA is a very fragile structure, and this is a transillumination study that's been described by our colleagues in Minnesota, which shows that the LAA walls are extremely thin. As you can see here, we're talking about 1 millimeter thickness of the LAA wall. So this structure is extremely fragile, and reminds us that we have to be very careful with the different procedures that we perform. The LAA is also a very variable structure. So for those of you performing structural work and performing TAVI, for example, when you're doing TAVI, you're essentially putting a tubular structure, which is the device, within another tubular structure, which is the aortic complex. Now, when in comparison, when you're performing LAA closure, you're essentially putting a plug, which is not necessarily a tubular structure, into a very variable morphologic cardiac structure, which could be the shape of a chicken wing, a windsock, a cauliflower, a cactus. So it could become somewhat more complicated to position the device properly. And the other thing is that the LAA is not only a variable structure in terms of morphology, but it's also a variable structure in terms of orientation. And this is a study that we've performed a few years back, where we describe the optimal projection plane of the landing zone of the LAA and for different patients. And for example, if we want to be perfectly perpendicular to the landing zone in this patient, in the top blue line, we would have to be in an AP view with 30 cranial. And if we want to be in the same orientation and perfectly perpendicular in this other patient, we would have to be again in AP, but in caudal 50. So you can see that there's a huge variation between patients, which means we cannot use a single implantation view for all patients. There's important variability. The third point is that the LAA has no fluoroscopic landmark, which means that the operator has to rely on TEE and the echocardiographer. So again, for those of you who perform TAVI, as you know, you have the pigtail that you could use as a landmark. You have calcification on the valves that could also help with respect to landmarks. But in LAA, there's absolutely no calcium or other landmarks to help guide the procedure. So therefore, you're essentially trying to paint with a blindfold on and rely on what TEE can show you and what your echocardiographer can tell you. So what are the ways that we could use to, what are the different technologies that we could use to improve this? We'll be discussing about MSCT fusion in a few moments. The concepts of the challenges that are associated with the procedure may lead to different complications. These complications include device malposition, device embolization, perforation, tamponade, injury to surrounding structures, and stroke. And while these complication rates have been going down over the years, complication rates should be as low as possible, because this, we must remind ourselves, is a preventive strategy. So this is where MSCT fusion imaging comes in. It's to help both with the safety of the procedure, so to reduce complication rates, and also the efficiency of the procedure, so to make this procedure more smooth. The Valve Assist 2 system provided by GE allows us to plan, guide, and assess the procedure. So we'll be discussing more about these two aspects. So the first two, the planning and the guiding. So with respect to planning, the MSCT fusion allows to easily segment the 3D CT images of the left atrium to precisely plan the intervention, and this includes morphology, landing zone, and optimal device size. And then most importantly, with respect to guidance, this allows us to significantly reduce procedure time, so efficiency, again, with the help of CT to X-ray image fusion, and this also decreases contrast media and cine dosages. And now we'll review this a little bit more into detail. So first, the use of MSCT to plan the procedure. So we perform MSCT before each of our procedures. and we trace the landing zone, as you can see here, and this allows us to select the device size. And this is a study that at the bottom here was published in JACC Intervention in 2016 that showed that CT imaging with CT imaging device selection was 100% accurate. In comparison, with 2D TEE, about 62% of the patient would have required larger devices, and with 3D TEE, 52% of patients would have required larger devices. And now, for those of you who are performing transcatheter valve implantation, this reminds us somewhat of our early experience with TAVI when we were relying largely on TEE, and now MSCT has supplanted that because of these discrepancies in device selection sizes. The other thing that MSCT helps us with is implantation view. So as you can see here, this is the landing zone that's perfectly perpendicular. So this is a view that's perpendicular to the landing zone, and MSCT allows us to derive the fluoroscopic angulations associated with this implantation view. So as you can see here, we would potentially try to implant in this patient in the RAO30 cranial 5 view. Okay, so the MSCT allows us to not only plan the device size, but also plan the C-arm angulations. Now, what are the concepts behind MSCT fusion? The concept is to take advantage of the work done during CT sizing by overlaying the CT model of the LA and planning lines over the fluoro. So as you can see here, we've done some planning with respect to transeptal puncture, landing zone. We've traced some lines with respect to the different lobes of the LAA. And this is our fluoro view, which again has no landmarks. And now if we perform fusion, we can now overlay both of those together, and this could help us during the procedure. Now we'll look more into detail how this is performed. So how this is performed, the first thing we need to understand is that to correctly orient and overlay our structures, our three-dimensional structures, we need to register them in two different views. This will allow the structures to be perfectly oriented in all three dimensions. So first, we need to understand that we have to identify landmarks that are visible in both fluoro and CT. So an example of this is the bronchi. So we first, to fit this with our clinical workflow, we first align the bronchi in the AP view. So as you can see here, we've delineated the bronchi in blue on our MSCT, and we will align those with the bronchi that we see on fluoro. Next, we can perform our transeptal puncture. We go into our working view. We'll do an injection, and we'll do a second alignment. As you can see here, we align the three-dimensional structures on CT and fluoro. In a second view, we are sure that both structures, so the LAA in MSCT and fluoro, are perfectly fused. And now what's important to understand is that the CT overlay is not fixed. It follows the C-arm and the table movement. So this is an extremely interesting feature. It means that you can change your C-arm orientation, and your 3D MSCT overlay will also follow the C-arm orientations and the table movements. So none of this is fixed. Now we'll look a little bit more into detail on the exact workflow of how we perform our fusion. So first we do our CT planning. So we do device sizing, we put our planning lines, we define our working view for the deployment. Next, we do our first registration in AP view based on the bronchus carina. As you can see here, those are aligned. We then do our transeptal puncture. We use the planning line, as you can see here, of the fossa ovalis to guide the puncture along with TEE. So this puncture is always performed very safely. Next, we go into our implantation view. So if you recall correctly, in this specific patient, it was RAO30 cranial 5. and then we perform a second registration based on a pigtail injection of the LAA. So we do a fine-tuning alignment of our MSCT 3D structure based on this injection. And then finally, we perform the deployment of the device guided by the LAA contour and the landing zone planning line. And at the end, we do a final assessment performed with TEE. So this is an example. We'll go through an example from A to Z of MSCT fusion. So here's an example where there were two lobes in the LAA. There was a green path, as you could see here, that was a little bit more anterior here and here. It had the best depth for the device. So this was the lobe that we were targeting for our implant. Measurements show that we would either use a 24 or a 27 millimeter watchman. So you could see that the LAA landing zone was 24 millimeters by 20 millimeters in this specific case. So this was compatible with 24 or 27 millimeter watchman to be confirmed by echo. And the planning also shows that if we position the device as planned, it will appear a little bit deep on the left pulmonary vein ridge, as you could see here. So it would appear a little bit deep if we position it here. However, it will be perfectly positioned on this side, on the mitral side, without any protrusion. So this was our targeted final position for the device in this specific patient. Next, we did our planning of the transeptal puncture site. So we align ourselves with the LAA, and then we trace a circle around the fossa ovalis. Of course, we always have TEE confirmation of each step as performed by our echocardiographer. So this is live during the procedure. The 3D TEE sizing of the landing zone was 18 by 20 millimeters. So this confirmed the choice of a 24 millimeter watchman device. So here's the transeptal. Live during the procedure. So we're moving from the SVC to the fossa ovalis, as you can see here, and you can see tenting on the TEE. As you can see, we've already performed our registration, and our Mullen sheath is correctly positioned in the blue circle that we had planned in advance. Next, we check our correct position by echo, and we perform the puncture, as you can see here. And we can clearly see on the fluoro when the septum is crossed. Okay, so the next step is to put our stiff wire in the left superior pulmonary vein, as you can see here. So the stiff wire is now going up the left superior pulmonary vein. It's not going into the LAA, as you can see on our MSCT fusion overlay. And this is, as always, confirmed on TEE. So the following step is to introduce the delivery sheath. As you can see, it's already been introduced. We introduce a pigtail in the LAA. So as you can see here on the left, it's initially going towards the mitral, then it's going towards the left superior pulmonary vein. And then with a little bit of counterclockwise rotation, we eventually find our way into the LAA. We double check that on echo to make sure that everything is okay. So next we go into the working view. As you recall, it's the RAO 30 cranial 5 for this specific patient. And we would then do an injection in the LAA through the pigtail. And now we would do our second registration. So we would just make sure that our MSCT fusion overlay is correctly aligned with the LAA structure itself as seen on fluoro. So this is our second registration. Now we are confident that the fusion is accurate. And now we can start moving our C-arm, the table if we want, and the 3D structure will follow. The overlay will follow the C-arm and the fluoro. We can see our planned landing zone as shown here with the orange line. As you can see here, we could add different features to the overlay, so we could have a full 3D overlay with the different lobes shown with the yellow and green lines as well. So the next step is to start advancing the device slowly. For the 24 millimeter device size as we've selected, we should have the landing zone in between the first and the second ring of the sheath, which are shown here, which means that we have to retract the sheath slowly as we advance the device. So this is what we're doing here. So we're slowly, during the deployment, retracting the sheath and advancing the device. We always keep the proximal part of the device at the level of the landing zone, as you can see here. So if we did not have fusion imaging, we would not have this landing zone as we can see on the right side here. So the fusion imaging really helps us with the positioning of the device. Here it is as we're about to unsheath in the middle. And now the device is fully unsheathed. Obviously, we always confirm all of this with TEE. Next, once we're satisfied with the positioning, we perform a tuck test. As you can see here, we're pulling on the device goes back into its position when we stop pulling. And finally, we do a final assessment where we inject into the LAA and we look at the position of the device. So the device in this specific case was perfectly positioned as we had intended, so it's vis-a-vis the planning line or the landing zone. As you can see, it appears a little bit deep on the left superior pulmonary vein side, but it's perfectly positioned on the mitral side. So this was expected, and we were very satisfied with the position in this case. We do a final assessment by echo to make sure that the device is properly, has the adequate level of compression. And then we release, as you can see here. So looking at our own experience now with the MSCT fusion technology, so since March 2016 in our center in Massy, we've performed now over 50 cases. About 60% of the cases were performed with the Amulet device and 40% with the Watchman device. So this slide here is a paper describing our initial patients, so the first 16 patients with the fusion. We've had no complications, as you can see here. And what we've noticed is greatly reduced volume of contrast for the procedure, so 95 before fusion and 21 with fusion. We've noticed also a reduction in total fluoroscopy time from 8 to 6 minutes, and also a reduction in total procedure time from 90 to 60 minutes from before to after the fusion. This slide shows the use of another fusion modality called the Echo Navigator. So in this study, they've shown that the radiation dose to the patient was greatly reduced from 70 to 48 grays per centimeter square using the Echo Navigator. Now in our study, in our first 16 patients, the radiation dose was actually 16 grays per centimeter square. So when comparing the Echo Navigator to our MSCT fusion, the differences were still significant between the MSCT and the Echo Navigator. Now these doses may appear trivial for the patient or operators, but what's important to remember is that they're not for the echocardiographer who's relatively close to the patient during the procedure. So every reduction in dose is actually a very important outcome. Now the caveats of MSCT fusion imaging, because there are some. First is the hemodynamic conditions of the patient and the filling pressures that may be different between the day where the CT was performed and the day of the procedure, and this may affect the sizing of the device. So it's always important to confirm every measurement by TEE. So this is why we still perform our procedures with TEE, both for sizing confirmation and for device positioning confirmation. And the other thing is that the 3D overlay does not move with the heartbeat or the respiration. So these features can be implemented, but this can be somewhat disorienting to the operator, because there would be a lot of movement on the screen, both the catheters, the structures, and the overlay. So we're not sure if it's necessarily the right way to go. Having these structures fixed on the screen may potentially be the best way to perform the procedure. Other uses of fusion imaging, so we've shown today MSCT to fluorofusion, but we could also do MSCT to MSCT fusion. So in patients who have had pre and post-procedural CT, as you can see here, we can fuse both of those volumes to show the appendage both before and after the procedure with the device in place. And this could give us some indications with respect to device sizing and positioning, and potentially guide us in the future to improve both of these variables. So in conclusion, LAA closure is a preventive strategy to reduce the rate of stroke by excluding the appendage. Risks of complications still exist, and a step-by-step approach guided by advanced imaging modalities such as TEE and MSCT to fluorofusion can decrease the rate of complications, decrease procedural time, and decrease contrast media volume and fluoro time. Thank you all for your attention.
Thank you, Dr. Spaziano, for a fascinating presentation showcasing some truly innovative technology. Now, we've had a great response from our audience, so if it's okay with you, we'll dive straight into the questions. So
sure.
The first question we have is a general question, which is, what are the contemporary rates of successful implantation for left atrial appendage closure?
Sure. Well, as you probably know, Dr. Cook, in a recent post-FDA approval study published in the United States, our American colleagues found a successful implant rate of about 95%. With a very low complication rate, the tamponade rate was about 1%. And this is keeping in mind that 70% of the implanters were actually new implanters that were not part of any clinical studies beforehand, and those implanters did 50% of the procedures. On the European side, our Italian colleagues published a registry where they described 2% tamponade rate. In our own center, we've had, in over 100 implants, we've had 2 cases of tamponade. In both of those cases, we did not use the fusion imaging. And since we've been using the fusion imaging, we have not had any major complication rates such as tamponade.
Right, so impressive figures. And it looks like the technology that you were showcasing may have a role in driving those complication rates down yet further. And sticking with sort of clinical indications for left atrial appendage closure, are there any definitive contraindications to having this procedure?
Well, in our center, obviously, if there's a thrombus that is seen into the left atrial appendage, whether on the CT scan or on the TEE during the procedure, then we would not go ahead and not do the procedure. We would anticoagulate the patient if possible and then reschedule him. Another potential contraindication is if there's an ASD or a PFO closure device in place, then that would be for us a contraindication. And then finally, we have to keep in mind that these patients should have non-valvular atrial fibrillation. Therefore, patients with mitral valve stenosis or a cardiac tumor should be excluded from such a procedure. The other thing is obviously the anatomy. So the LAA anatomy should be suitable for either device before going ahead and doing the procedure.
Great, thank you. That's very clear. And in fact, one of our audience members has asked, is it ever challenging to detect mobile thrombus using CT imaging?
It could be. That being said, there's a very elegant review from the team in Vancouver from Jackie Saw, published in 2016 in CCI, and they describe different techniques and strategies to improve the visualization during CT scan, and one of those is to do both early and late images. And in that situation, a filling defect that would appear on the early images and that would lead you to suspect that there's a thrombus could potentially disappear in the late images, and then you would understand that it's actually not a thrombus. So that's one strategy that we've used regularly on our CT scans to improve detection. Right,
I understand. And how accurate, in your experience, is the CT sizing compared to the transesophageal echo sizing that is performed during the procedure?
Well, in most of the cases, the sizing with CT is more accurate. So we've had appropriate sizing in over 80% of our patients. The advantage with CT is that you're always in the perfect orientation because you decide the orientation and how you sort of cut the landing zone to make sure that you're in the proper orientation. And in that regard, usually the devices that are chosen with CT are somewhat larger than those that would be chosen with TEE. And this may be both related to the way you image and you slice your appendage, and also to the feeling, the hemodynamic conditions of the patients on the day of the procedure.
Right. And do the characteristics defined on the CT scan ever determine which device you actually use?
So that's a good question. I think I'd like to make another parallel with TAVI here. As you know, about 90% of your TAVI patients could undergo the procedure with either device, whether it's an Edwards or a Medtronic core valve. I think in our experience, it's more or less the same ratio for left atrial appendage closure. So about 90% of the patients could undergo the procedure with either device. And then there's a 10% where you could potentially use one device more than the other for certain anatomies. I'm thinking maybe for chicken wing anatomies, maybe the amulet device. We've had good experiences with that rather than the Watchman device. But again, this is on a case-by-case analysis, and I don't want to be dogmatic.
Sure. No, fully understand. And another question from our audience is, should the landing zone measurements be made in atrial systole or diastole?
So that's a good question. We usually do both. And one thing that's good to remember is that the left atrial appendage is relatively stable throughout the cardiac cycle and doesn't change diameter or size too much. And usually you would get very similar measurements, whether in systole or in diastole. We typically do our measurements in both, and then size according to the average of both measurements. That's the way we usually do it.
Great, very clear. And another question from the audience is, do you have any specific protocol for the CT scan in order to acquire the data set that you need for this fusion imaging?
There's no specific protocol. We use the same protocol as we do for our TAVI study. So obviously your CT scan has to be gated. And then we'll take usually a 75% phase, which is in diastole, and a 35 to 40% phase, which is in systole, and look at both. And we'll do like I said, a late image just to make sure that there's no filling defect into the left atrial appendage. But otherwise, it's just a regular pre-TAVI CT scan.
Great. And are the CT fusion technologies that you showcased in your presentation available for clinical use now?
The one from GE is available, and it's a software upgrade, so you don't need any specific hardware to use it. Other companies also showcase similar technologies, such as the Heart Navigator by Philips, and all of those do not require any hardware upgrades, I believe.
Fantastic, thank you. And now a slight change in direction is, are there any specific antiplatelet or anticoagulant regimes that are needed to treat patients with left atrial appendage closure?
This is a very good and difficult question to answer, Dr. Cook. What we've seen so far, what we know so far from our French colleagues, is that about 5% of patients develop thrombus on the device after the implantation. Of course, this is seen either on transesophageal echo or on CT scan, and those 5% of patients are actually at an 8-fold increase rate for ischemic stroke. And the other thing that we found, or that they found, is that protective factors from this thrombus that we can see on the device include DAPT. So patients that are on DAPT have 10 times less risk of developing this thrombus on the device, and patients that are on OAC, or oral anticoagulants, have a 4-fold decreased risk of thrombus formation. So we do know that DAPT and oral anticoagulation reduces the risk of thrombus, which then in turn may reduce the risk of ischemic stroke. That being said, these patients are usually at absolute contraindication for vitamin K or antagonists or NOACs. Anyways, in France, they have to be either at extreme risk of bleeding or have a prior bleed. So therefore, in our case, we usually give some dual antiplatelet therapy after the procedure for at least 6 months, and then we would typically get a CT scan and make sure there's no thrombus on the device before discontinuing one of the two molecules, either the aspirin or the P2Y12 inhibitor, and this is based on a case-by-case analysis.
Fantastic. That's very clear for the audience. Thank you. We've had a number of questions now wondering whether or not there has been any economic analysis of potential cost-saving benefits of using the CT fusion technology.
That's a good question. Not to my knowledge. This is an interesting question. I'm not aware of the exact costs of the technology and what are the economic impacts. One thing I can advocate for is that the technology itself actually reduces procedure time quite a bit. Obviously, as experience grows, procedure time goes down, but this for more inexperienced operators could actually improve the learning curve of the procedure and actually get through the procedure much quicker and much safer.
Sure, absolutely. And we've got a question here regarding what are the specific benefits of using the CT Angio Fusion instead of 3D echo fusion for the transeptal puncture in particular?
For the transeptal puncture, that's a good question. We typically use both at the same time. So when you fuse the CT with the angio, you have that blue circle which we've seen in the presentation, and that gives you a good idea of where you have to position the needle. So when you start off, before going through the transeptal, you usually start off in the superior vena cava, and then you would go down with your needle as you rotate. The TEE, 3D TE, cannot help you with the gross position of the needle at that point. It usually helps you once you're very close to your puncture site to fine-tune the location to go posterior and inferior, as you know. So it's a question of using both at the same time. So the general location of your transeptal puncture site will be performed using the fusion imaging, and then the fine-tuning of that transeptal location will be guided by TEE.
I understand. Thank you. And what are the echo features of suboptimal deployment of a left atrial appendage device?
So we do confirm on echo, as always, the correct positioning. So the things you have to look for, first you have to make sure that the maximal diameter of the device, and again this varies for both of the devices, so the indications and the things we have to look for are not the same, but I can say for the Watchman device, for example, that you have to make sure that the maximal diameter of the device has to be at the ostium, and has to span the entire ostium of the LAA. And the other thing is you have to do an anchoring test or a tuck test where you pull on the device and you have to make sure that it stays in place. You have to look at compression also of the device. So the deployed device diameter by TEE and by Angio, if you can, has to be a diameter that's about 80 to 90% of its nominal diameter. So it has to be somewhat compressed by a level of 10 to 20%. And then finally, you have to assess sealing, and this you do by echo, and you can verify if there's leaks around the device, and if there are, these have to be less than 5 millimeters. Otherwise, that's an indication that your device might be not optimally positioned, and in that scenario, then you would consider recapturing the device and then redeploying it.
Fantastic, thank you. And we've got one last question from the audience here, which is quite a big question, so try your best to answer it. But it's
Sure.
what do you think are the main limitations of the current evidence base for left atrial appendage closure?
That's a good question. One of the things that we have to look at is the comparisons with NOACs, because now currently patients are currently being treated for atrial fibrillation with new oral anticoagulant agents, and all of the comparative studies that were published so far are usually comparative studies that compared left atrial appendage occlusion with vitamin K antagonists. So the contemporary question is looking at NOACs, and we may get some answers regarding this question with the PRAG 17 study, which is going to enroll over 400 patients in the Czech Republic, and those patients are going to be randomized to either left atrial appendage occlusion or anticoagulation with any of the new NOACs. And this might give us some answers with respect to how this technique and technology positions itself in the contemporary treatment of atrial fibrillation.
Fantastic, thank you. We've just had a question come in live now, which is there any value of 3D printing of the left atrial appendage architecture to help with procedure planning? Are you aware of any technologies looking at this?
Can you repeat the question, please? I didn't quite understand.
So the question from the audience is, do you know of any innovation in the field of 3D printing in order to aid procedure planning for left atrial appendage?
There's been a few case reports describing 3D printing for complex anatomies, and those have been successful. I haven't heard of any either randomized trials or large case series describing this specific technique.
Great. Well, thank you so much, Dr. Spaziano, for answering our viewers' questions. It's been a real pleasure having you with us today, so thank you very much for joining us.
Well, thank you all for being present, and thank you, Dr. Cook, for hosting this great webinar.
Great. So that was Dr. Spaziano speaking to us live from McGill University Health Center, Canada. You can find out more about Dr. Spaziano in the link under this video. So it just remains for me to say thank you, our audience, for joining us today. As ever, we would be very grateful if you could rate this webinar using the star rating system on your screens. If you have enjoyed this learning experience and want to listen to our other webinars, please turn to the Academy section of our website at radcliffecardiology.com/academy/webinars. So that's all from me. Until next time, thank you and goodbye from Radcliffe Cardiology.